Thank you, Steve. First, I'd like to thank the organizers for their kind invitation, as always. I do look forward to this meeting every year. I've been coming since around 2003, and it's a great way to start the year, to meet all of the friends in Thailand, and to really come up with some good research ideas for the coming year. So my role today is right at the end of the meeting to really tie up a few things and come and looking at HIV therapy in the era of polypharmacy. And before I get into the polypharmacy a little bit, I thought it'd be nice just to take a little relaxed look back over the last 30 plus years about the drugs that we have in terms of HIV. And it's quite an impressive achievement. And if we look back in 1987, where the AZT was the first drug approved for treatment of HIV/AIDS, I was still at high school. But then things did move on quite quickly. We have the NNRTIs, basically copying AZT. And then we had the first PIs in 1996. And then the first NNRTIs, also in 1996, where we now introduces, HAART, or now antiretroviral treatment. Then we had, don't worry, I'm not going one by one. We have then the big innovation of drugs being produced. 2007 is the first integrase inhibitors, and then other integrases and other proteases and things. So there's been a huge production of antiretrovirals, a fantastic scientific achievement actually to produce all these drugs. And obviously some of them are not used today. Maybe a lot of you in the past 15 years ago were prescribing, Indinavir or Sequinavir, but these drugs are now well in the past. So I've had to now update this slide as well, and I think it's very important. These ones in the boxes are the ones which are now really transformed HIV in terms of fixed dose combinations. And I always like to point out the one in Thailand was the real originator when it came to fixed dose combinations with GPOVIR, which was a D4T3TC nevirapine based twice daily regimen. And then a lot of other fixed dose combinations which we know very well today are produced. And that was only up to 2004, and recently I've had to update this slide now to go to the more futures, and there's lots of new other drugs, but they're not that many new drugs now, but primarily mixing the other two drugs together, apart from perhaps cobicistat. But this dolutegravir pivirine regimen, that's dual regimen that's just come out, will be again, the first dual regimen that's been used for treatment in certain. Then we have the TLD, which we've heard a lot about in this conference, which is going to be hopefully in Thailand sometime this year, but it's rolled out in South Africa already. Then we have doravirine, which you've heard about, and all of these perhaps different twists on different formulations over the years. And again, the talk just before this morning from Dan Koeskas looking at, we have fostemsavir, which is an attachment inhibitor, which is going to be maybe come out for adults. I am involved in the pediatric study of this drug, fostemsavir. They've come up with the name, it's called the SHIELD study. They come up with these crazy names sometimes, but it's nice. Then we have these VCRS01, which is these monoclonal antibodies, and perhaps not so more now the histone deacetylators. So there are still drugs coming out. And we've seen again that we have these, multiple drugs over the past going to one tablet once a day, now perhaps one monthly injection, or even quarterly, yearly, whether oral or even longer, who knows. But so there's a huge advancement in antiretroviral treatment. So when I'm talking about polypharmacy in a few moments, we're not really talking about the antiretroviral polypharmacy, because we have these very good, simple formulations now, 2 or 3 drugs, and etc. But last slide before I get into the polypharmacy, is that we always forget the children, and I wanted to put one slide on the children, because a lot of the formulations you see on that beautiful, timeline I showed, not all of them can be used in pediatrics. It's always very nice for adults, but we still even using drugs which probably are not prescribed to adults anymore in children. For example, lopinavir ritonavir, and this is the first fixed dose combination. It's just been submitted to the US FDA last year. It's a lopinavir-based fixed dose combination for children. It's called the 4-in-1, and they've just given it a name, I think, Quadrimune. And it's being studied in the Lollipop study in South Africa, which is in HIV-infected children. And it's also going to be studied, again, in another great name for a study, the PETITE study, which is going to be in neonates. And this is not necessarily for treatment of HIV-infected children. It's for those infants born to high-risk mothers and to give them triple prophylaxis to try to prevent the treatment. So there are still new formulations coming out for children, hopefully. So back to the polypharmacy, which is my goal for this talk. And the first question you were asking is, what is polypharmacy? And the definition in the scientific literature is really the concomitant use of 5 or more medications. Sometimes it could be 4, 5, but in general, it's around 5. And I have a little footnote at the bottom. In this presentation, it's really going to be excluding the HIV drug. So it's 5 non-HIV drugs so it's the concomitant medications on top of the HIV therapy. And this is a recent study that just came out at the end of last year or before, and it's a big study in the US called the MAX study, and this is in men in the US, MSM, who are either HIV infected or HIV negative, and they followed them, and this is a study looking over the last 12 years of what drugs they were taking and when. And if we look at the different bar charts here, I know it's a bit small. HIV positive is red and HIV negative is blue. At the top is more than 50 and below is less than 50. And as you see, when you're less than 50, you're not taking the percentage of people with polypharmacy, meaning more than 5 other concomitant drugs, is quite low, less than 20%, but perhaps a little bit more in HIV. But clearly when you get over 50, you see this sort of differentiation between the red and the blue bars, and it's higher than the bars at the bottom. So when you get to 50, you have more polypharmacy, and I mean, it's not brain surgery. We expect people as they get older probably be taking more drugs, but there is still that differentiation, even though in HIV-infected patients versus non-HIV infected patients. But then I thought, what about outside the US? Let's look at is there any data in resource-limited settings where most of the HIV-infected individuals are? And I found this nice paper recently, again, this is in Uganda. This is only focusing on HIV-infected adults who are older than 50, and they found a rate of polypharmacy around 15%, which was lower than what we saw in the US, which is around 25%. So could it be to different access to different drugs, or, you know, there may be more, you know, in the US, maybe easier to prescribe other drugs for different illnesses. So it's unclear. But clearly polypharmacy is not just limited to resource-rich setting, but it's also going to be for a resource-limited setting as well. So what are the established risks of polypharmacy? I mean, clearly when you're giving multiple drugs together, there's going to be an increase of serious drug adverse events, organ system injury, perhaps more hospitalization. On the alternative side, we could say decreased medication adherence. However, I've just convinced you that for the antiretrovirals, at least, that shouldn't be an issue in some instances. Mortality, if it's can happen as well. And this is really the cause of all these underlying issues, which were the risks, as really, you know, drug-drug interactions, whether it's, you know, drug-drug, but it also could be with food, other types of interactions which, you know, that can happen when you take these antiretroviral treatments with other medications. So what happens when you look at the drug-drug interactions in these HIV-infected adults, and this is a large Swiss cohort looking at polypharmacy and drug-drug interactions in about 1,000 patients all over 65 years old. Again, the pie chart at the top is a little bit small, but what I was trying to show here that in this setting, most of the individuals in this cohort are now on integrase-based inhibitors, probably about 50%, which is the ones below 65 and on 65. And then when we look at, again, on the left, less than 65, more than 65, and these are the different, you know, non-HIV drugs they take, and then the different colors represent. Green means low risk of drug-drug interaction versus red on the extreme, which is more interactions or risk of interaction. You can see that there are clearly some instances where people are prescribing medications where there is a risk of interaction. But this is also in the setting of, you know, integrase, high use of integrase treatment. So then again, I switched it to say, what about in a non-resource limited setting? Are there similar situations? And this was a large cohort in Tanzania where they looked at, again, in rural Tanzania, where they had around 33% of the adults who were looking at polypharmacy where they had a risk, at least some risk of potential risk of drug-drug interaction, with only around 2% with, you know, the red interactions, which are more serious. But nevertheless, this is probably going to increase over time. So clearly there needs to be more understanding of, you know, the type of drug interactions and the real risks which are associated with them. So for drug-drug interactions, when companies develop these drugs, they do drug-drug interaction studies of the most common one. We've all looked in the package insert, and there's 4 or 5 pages of these tables of looking, I can't remember all this. So it is possible, but it's impossible to do all drug-drug interactions. And I think we have to be very wary of that, because when you look, serious drug-drug interactions can occur even for the approved drugs, because, and if you look in the literature, I just found a few here quickly looking at fatal drug-drug interactions of approved antiretrovirals, which can occur. So these case studies which come out, we have to be wary of them because maybe it hasn't been used together. So we can look for these individual case studies, which if you have one, I think is important to report so that others are also wary of what could happen in that situation. So these drug-drug interactions are often not serious, but in certain situations can be extremely serious. And how do they occur? And I think maybe you've seen this slide already, or a combination of this kind of slide. I'm going a little bit more teaching now rather than research, but when we have drug-drug interactions, we really focus either on the liver enzymes, which in this table is obviously the cytochrome enzymes, or the UGT enzymes, which are in the liver. and we have drugs which are victim drugs or perpetrator drugs. So for the most of my presentation, the victim is going to be the antiretrovirals, where the perpetrator, the bad one, which is causing the effect, is something like rifampicin. And even going a little bit more cartoon, I know it's the last session of the meeting, so we just go a little bit basic, but I think it's nice to see sometimes to visualize actually what is really happening. And so if you had an inducer of a drug in here, so this is a very nice rectangular hepatocyte, and then you have a drug, it's going to be metabolized by cytochrome 3A4, normal situation, but then you add this other drug on top, you have the victim, the perpetrator, and that perpetrator then can, stimulate the production via nuclear transcription to produce more enzymes, and then it's going to make the drug eliminate faster. So that means you're going to have lower drug levels, lower efficacy, but on the other side, which I don't have a slide, it could go the opposite. It could inhibit the drug and then increase the concentrations. But drug-drug interactions aren't all about enzymes. Often we think about cytochrome enzymes, but it's also to do with transporters. So then I am the first to admit I cannot remember the names of lots and lots of transporters, and on the slide there's about 5 or 10 transporters, but there's some which are influx, meaning taking the drug into the cell, or efflux, kicking the drug out of the cell, and most people know P-glycoprotein is the most common drug or transporter kicking things, not necessarily drugs, outside the cells. But if you have, for example, the gut here on the left, an oral drug is taken in, it has to get into the blood and before the circulation, and these drug-drug interactions could occur at many different steps, either transporters or enzymes. So knowing the mechanism can help whether to see if we can overcome this interaction as well. So the next slide here is just to, as many of you probably know, and I'm going to mention it, there is a website where they're called HIVdruginteractions.org, which is done by the University of Liverpool. And what this slide is showing is that if you just plug in a drug, it might give you the potential for it to give drug-drug interactions based on its known mechanism, knowing which enzymes it's metabolized, knowing which transporter it's in. So if you look at these common drugs like dolutegravir, on the upper part, it's very green. So just because the way it's metabolized and it's transported, it's not expected to have a lot of drug-drug interactions. When you compare that with the boosted antiretrovirals, you see that, it's only half green, you have some red. So, and obviously this is because they have this, ritonavir or corbicistat, we can induce or inhibit the enzyme. So the chance of increasing our drug-drug interactions is a lot higher. And for efavirenz, we've seen probably many presentations where it can induce the enzyme activity and therefore reduce the concomitant drug. So a common question everyone's going to ask and say, who cares about drug-drug interactions so much? When should we care about a drug-drug interaction? And this is what someone mentioned. This is a good definition of when to care, but it's still not phenomenally clear. So when is a drug-drug interaction important? So when co-administrated, it leads to safety, efficacy, or tolerability issues greater than when administered alone. And that's pretty obvious, to be honest. But then we have to think, okay, if you take a drug and you give another drug, the levels go up by 20%. Is that a problem or not? 30%, 40%, 50%, 200%. When should we start to concern? And obviously, this is when you have to take into account the toxicity-related exposure-response relationships, which need to be defined as well. But polypharmacy can occur at many different stages of somebody's life, depending on if you have an individual living with HIV who started treatment, there's different types or different parts of their life, if they were infected perhaps early in life, in young adulthood, where they may have polypharmacy. So if you are early on in treatment, you may have comorbidities like TB, or you want to treat latent TB or pneumonia or other opportunist infections, so you're going to have polypharmacy because of the TB drugs. But later on, maybe you were, when you were a young female, for example, or 25 years old, they might want to take contraception. So that's another issue where you might have polypharmacy, or you want to take vitamins. But then late in life, which we've seen in the polypharmacy studies I presented on the first few slides, it's mainly for illnesses which are related to older age. So again, and I'm just going to go through the next 5-10 minutes looking at each of these situations where polypharmacy could occur and what we need to be aware of. So the first one is TB treatment or latent TB treatment. And again, I think everyone is probably aware after a 3-day HIV conference that the rifampicins with TB affect antiretroviral drugs. And this is because they induce the cytochrome enzymes and also it can block the transporters. And we can see among the rifampicin is the bigger inducer, the one that causes the most enzyme induction. versus rifapentine and rifabutin. But we're going to focus on rifampin, or rifampin. And we see here in Asia, for at least, everyone is giving efavirenz 600 milligrams until the Encore study came along and said 400 milligrams. So then we see that, well, what happens? We know TB drugs do decrease efavirenz a little bit. So when you give 600, it's fine. It's fine to give. But what happens when you give 400? And this is a recent study I think just presented at the end of last year, where they tried rifampicin using the 400 milligram dose, and they found that the levels were also lower, but still all of the individuals had HIV suppressed. This is of note, this is in individuals without TB. So they did this study just to look at the drug-drug interaction. And this red line at the bottom of the graph is just to say that the concentrations when you give efavirenz 400 milligrams once a day with rifampicin was still above that line. But the next question I ask actually is just more of a research question, is what happens if you had a pregnant woman and TB and efavirenz treatment? Because even we know for efavirenz in pregnant, forget the TB for a second, the levels are a bit lower. So here you're going to be pregnant, lower, efavirenz 400, lower, rifampicin a bit lower. So are you finally going to cross that line? So I think that's a little bit of an unknown question. If you had TB, it can happen, but it's not so much in Thailand, although in our site in Chiang, we have had, over the last few years, quite a few women with TB who needed HIV, needed TB treatment. There's a fly on my thing here. So dolutegravir, I put dolutegravir in because this is a drug that's going to be rolled out. It's not currently in Thailand, but it will come in the next 2 years and in other Southeast Asian countries. And again, you've probably seen this in Dr. Anjali's presentation yesterday, where we're looking at how do you overcome the interaction of dolutegravir with rifampin. And actually, the normal dose of dolutegravir is 50 milligrams once a day, and this is the line here. I think you can see you can't see my mouse. And here, this is the normal dose. But actually, if you have resistance or suspected resistance to dolutegravir, they recommend to give it 50 milligrams twice a day, so you get these levels. And we know rifampicin will reduce dolutegravir, so this is when you give it with rifampicin, it shunts down. So this is the 50 with rifampicin. And then when you overlay that, it looks similar. So basically, they're saying that you can give double dose rifampicin, dolutegravir, with rifampicin to overcome the effect. And that's what is done. And I haven't got a slide on it, but there has been another study where they've done, instead of giving 50 milligrams twice a day, they've given 100 milligrams once a day. And in that study as well, they also tested 50 milligrams, the standard dose with rifampicin. And both of them, actually, they conclude is not too bad. So whether you really need to double the dose or you could do the double dose once a day is a little bit unclear. And I think they're going to do the studies now in HIV-infected and TB patients, because this study was in, I think, in healthy volunteers. The 100 milligram was also in healthy volunteers, but they want to study it in the actual HIV-infected plus TB. So I don't know the dose to give with rifampicin. Probably 50 milligrams twice a day is the best, but some might say, well, you could give 100 once a day. So for TAF, now TAF is a drug like tenofovir, and I'm sure you've used tenofovir widely over the last years. It's actually not metabolized, it's just excreted unchanged in the kidney. And again, I'm showing this slide for those who are, who sometimes get a little bit lost with all of these TAF, TDF thing and difference in TAF diphosphate. What is the difference between these drugs? And basically for TDF, it gets converted to TAF. If you take TAF as a tablet, it doesn't get into the body at all. This is why they made TDF. So then you take TDF, it gets immediately, as it gets into the blood, it becomes tenofovir. It goes into the cell, it gets activated to tenofovir diphosphate, DP, and then inhibits the HIV. For TAF, basically it just goes straight into the cell and then become tenofovir diphosphate. You don't get much tenofovir in the cell. And the reason I'm showing this slide is because when people look at drug interactions with TAF, TDF or TAF, sometimes they measure TAF, sometimes they measure TDF, and sometimes they measure this. So when you look at a drug-drug interaction with TAF, they actually measure the TAF, they measure the TDF, and they measure the tenofovir diphosphate. So when you're looking at the interaction, you need to know which one should I be looking at and which one should I care about, actually. Okay, the TAF level goes down, so what? I'm interested in this. So that's what they did in this study. They gave tenofovir, TAF, with the standard dose once a day with rifampicin, and you see the levels of TAF in the plasma go down, the level of tenofovir in the plasma go down, and the levels of the TDF, this is the tenofovir diphosphate, also go down. But then when you compare to the levels you get with the tenofovir diphosphate with TDF, it's still higher than that. So yes, it's gone down, but theoretically, it's still producing concentrations inside the cell which are higher than what you give 300 milligrams of TDF. So should that matter? So should the intracellular level be the driving factor for that interaction? So again, there's a little bit of clarity about which is the best. Can you give TAF with rifampicin once a day? Can you double the dose? Based on the intracellular levels, pharmacological-wise, it looks okay, but I mean, I think they still need to do some studies. My last slide on the TB treatment is, I just wanted to mention, we've heard a lot about, the long-acting cabotegravir, but there is an interaction with rifampicin. So if you had, this is a single dose or single injection of the cabotegravir, the green line, but when you give it with rifampicin, it goes down. And they have done some in situ modeling, this is not in patients, where they've tried to simulate what would happen here. If you give injections of cabotegravir, you add rifampicin, it's just going to drop like a stone, and then it's going to be low. So if you have an individual on a long-acting cabotegravir regimen, they get TB, hopefully not, then it's a little bit tricky to treat with rifampicin. So we have to think about that. I have a couple of slides on latent TB. I think this was discussed yesterday by Professor Chasen. Basically, with the 3-HP regimens, which are now coming in with rifapentine, dolutegravir can be given with 3-HP without a dose adjustment. So that's if you're thinking about using latent TB, do you want to give 3-HP? Do you want to give 1-HP? Now for 3-HP, dolutegravir, no problem. But for 1-HP, I think it's unclear whether it can be used dolutegravir. The next slide show that for 1-HP, at least you can use efavirenz that can be used with 1-HP drug-drug interaction-wise with rifapentine. So if you're thinking of treating an individual with, the monthly or the weekly rifapentine or the daily rifapentine for a month, you have to think with efavirenz, I think the 1-HP is okay. But for 3-HP, the dolutegravir, until we get more data on the dolutegravir with 1-HP. So let's move out of the situation where the individuals have, passed their initial treatment. They've been treated for those opportunist infections you have. Now we come on to situations where, they're not necessarily taking drugs for a specific illness, but they just want to take medications which are needed at that point of their life. For example, like contraception. So for oral contraceptives, we've known for quite some time that with an efavirenz-based antiretroviral therapy, it can reduce the progestin levels. It doesn't really have any impact on the ethylene estradiol, but it can, as you see on the graph on the bottom right, significantly reduce the progestin levels. And this is where it comes a little bit tricky to explain, because how low is the progesterone level needed to then, you are at a higher risk of pregnancy? I think that the threshold of what you say is, okay, this progesterone level has gone down, therefore you're at a higher risk of, getting pregnant on this medication, is a little bit unclear. So when people are looking at these types of studies, they're trying to look, what is this, how low for the progesterone is allowable to, then it's not working. But if we can try to, a lot of people have then looked at, aside from oral medications, can we, bypass the, the gastrointestinal tract and, use the implants, use the, the injections? How does that affect? And there's one of the studies that have been done quite recently is looking at the levogestonal implant, which is quite commonly used in Africa. And here they did a study with efavirenz and nevirapine in Ugandan women who were receiving who were implanted with the levogestonal contraception. And this is the levogestonal plasma level here. This is the blue line of levogestonal without any other antiretroviral. With nevirapine, you see it doesn't really matter. But when they gave efavirenz, the levogestonal level went really far down. And they proposed this threshold of 180, which is from an old paper, to say if you're below this, you might have a higher risk of pregnancy, but it's unclear if that is, the definitive threshold. And they had 3 pregnancies in this study out of 20 who were on efavirenz. So this was a concern if you're using an implant with efavirenz-based regimen. So what they did some modeling, and they said, well, actually, what happens if we give 2 implants instead of 1? Does that help? And you would think it would, but it didn't. So they gave 2 implants, and this was just reported earlier last year, and this is a similar trend. It was a little bit higher, but the levogeston level was still pretty low. So again, with an efavirenz-based regimen, an implant with levogestonal is probably going to have lower exposures. Now, whether that transmits, or it does seem actually to be associated with an increased risk of pregnancy. So I think using this implant with efavirenz is not a good choice. What about vitamins and antacids? Again, I think we've heard a little bit about this already. For the integrase inhibitors, it can be a problem. For dolutegravir, if you want to take calcium or iron supplements, this is the red line here. This is when you take dolutegravir with calcium carbonate, it goes down by about 38%. This is with the ferrous furamate, it goes down by 54%. So, but people are going to take these over-the-counter medications and other, but so if you take it 2 hours before, it seems not to be a problem, or you take it with food. So if you have one of your patients who wants to take, or for some reason is taking calcium or iron supplements with dolutegravir, you can do it. You just have to inform them about the best time to take it, whether with either take it with food or take it 2 hours before before the dolutegravir. And again, a similar trend when you give antacids, which are cations as well. They really reduce the dolutegravir and raltegravir levels. So anything, ions, cations, whether it's in an antacid or for a vitamin supplement, can have significant effects on the integrase inhibitors. But if you use a proton pump inhibitor like omeprazole, actually it doesn't really affect the dolutegravir concentrations, while it does affect the raltegravir concentration. So again, it's very drug specific. You can have the cations impact, then you have the proton pump inhibitors. Again, DTG okay, raltegravir not so clear. So finally, I'm just coming on to the older, as you get into late adulthood, the kind of illnesses or situations where you're going to need other medications. You have the statins, of course, and statins are actually the victim. So this is, we've talked a lot about, lower concentrations of efavirenz, dolutegravir, This is the opposite. Normally, antiretrovirals increase statin concentrations, and we know the risks of, the muscular effects of increased statin concentrations. And again, it's always to do with the enzymes and transporter inhibition. And it can even differ between different, boosting agents, because here you have cobicistat, ritonavir, which is probably inhibiting the cytochrome CYP3A4, so therefore the enzymes can be high. It's not metabolized as fast. So that even between, two different boosting agents, it can be quite a different effect. So if you're giving any protease inhibitor which is boosted, you're going to probably have issues with a statin. Even for rosuvastatin, which is not metabolized by cytochrome CYP3A4. It's an inhibitor of the transporters. So you think, this is not inhibited by CYP3A4, should not be a problem, but it still can be. So for metformin, for people for anti-hyperglycemic drugs, we've seen for dolutegravir, it can increase the metformin concentrations, and there are some sort of guidelines about, trying to limit the dose of metformin when given with dolutegravir to try to counter this effect. And this is really driven by, again, a transporter problem in the kidney, where metformin is shunted into the kidney cell here, but dolutegravir and bictegravir actually can block this and then increase the concentration. So again, it's not always enzyme, and they have to look at this. For bictegravir, compared to dolutegravir, the concentrations change was not as much, so if you had to use one of them, you would probably pick bictegravir. And I think finally, in terms of these kind of medications, I did recently look at interactions around the new directly oral anticoagulants. So here I have dabigatran. And again, this is similar to what we saw for the statins. There is an interaction between cobicistat boosted drugs and dabigatran, it increasing the dabigatran concentration, and actually the thrombin also was quicker. But when you give with ritonavir, it didn't have effect on it. So again, when you're giving these newer directly oral anticoagulants for different reasons, on top of antiretroviral treatment, it can be obviously drug-specific, but also booster-specific as well. So it's interesting that you would assume that there may be a similar trend, but it's not always the case. And this is my last slide, my last combination I'm going to talk about is the DAAs. We've seen hepatitis C treatments now becoming more and more available. These are the key ones. I know in Asia that all of these treatments are not available, but I just focus on one, which is the SOF-VEL or sofosbuvir-velpatasvir. And here we have antiretrovirals being, again, like the statins being the problem, when velpatasvir concentrations, when you give with efavirenz, are much lower, about 50% lower if you're on, TDF, FDC, that should be efavirenz. It goes down by about 50%. So even with the short treatment of 12 weeks of hepatitis C treatment, and you're on antiretrovirals, having 50% low concentrations of efavirenz for 12 weeks or 8 weeks, depending on how long you give it, it can be obviously an issue, and this is not recommended. Here's a summary of all of the interactions between hepatitis C. I think my time's nearly done. And you can see for dolutegravir, I just wanted to point it out that it's very green. So dolutegravir with the directly acting antiretrovirals, maybe not too bad. I showed you efavirenz with soft velpatasvir, and there are some tenofovir issues, but just need to be monitored. I'll skip that one, just go to my last slide. And this is a paper I just found a couple of days ago because I was giving this talk on polypharmacy, and then I found this very interesting paper that says, we're going the opposite way now, deprescribing of non-antiretrovirals. And they say that this word deprescribing was first in the literature in 2003. So this is, again, I'm not an expert really on this deprescribing, but I think it's people coming up in the era of polypharmacy, coming up with ideas or algorithms to try to say, well, actually, how can we try to, deprescribe some medications in certain patients where it's not necessary? So this might be something which is an area which is growing, and maybe they will come out with some, perhaps recommendation of how to be prescribed in certain situations. So my last slide is a pretty simple one, actually. Just talking about polypharmacy is basically common, particularly for HIV-infected and more than 50 years of age. It does occur in resource-limited settings as well. The trends and number of drugs are slightly similar, but I'm sure over the next 5 years, the difference between resource-limited and resource-rich will converge, and it will be exactly the same. And drug-drug interactions will happen. It's unavoidable. You have to do it in certain situations. You know the interaction, but you have no choice, so you're going to do it. So obviously you can change the medication, modify the dose. There's many things you can do, but hopefully most cases are manageable, and you have these resources like druginteractions.com who can help. And hopefully that the patients, if you know these interactions, then you can manage it. So I'd just like to thank David Back from the University of Liverpool and Kim Scarsy, who helped me with some of the slides, and for your attention. Thank you.